So welcome everyone to the Public Health Association of Australia's Political Economy of Health Special Interest Group webinar on equitable access to COVID-19 vaccines. My name is Dr. Belle Townsend. I'm Deputy Director of the Menzies Centre for Health Governance at the Australian National University, and I'm a committee member for the Public Health Association of Australia's Political Economy of Health Special Interest Group. I wanted to start by acknowledging the first Australians on whose lands we are meeting on today, wherever we are. For me, I'm in Canberra. I'm on Ngunnawal and Ngambri country, and I pay our respects to elders past, present and emerging, and acknowledge that sovereignty has never been ceded. Today, we've got a really great lineup of speakers, and we're going to discuss a critical issue during COVID, which is access to vaccines and the political economy dynamics. That is intellectual property, trade issues, local production and technology transfer needs, in particular for low and middle income countries in our region, but also for Australia's access to vaccines. And we're going to reflect on what the Australian government can do to facilitate equitable access to vaccines, and what we in the public health community in Australia can do to support that. So I'm just going to give you some quick technical things to know. So we're recording this webinar. Only the panelists are being recorded, our audio and our videos, so participants are not visible in the recording. And once we have the recording finalised, we're going to put it up on a YouTube channel, and then we'll send it around to everybody who's registered so that you can share it with your networks. And we have had some interest from colleagues overseas, so we'll be getting the recording out to them. We've got three speakers, and what we're going to do is take questions and have a discussion at the end. So if you have questions, please put them in the Q&A question box. You can use the chat as well, but the Q&A is preferred. If you're on Twitter and you're interested in tweeting throughout the webinar, we thought we would have a hashtag access2, so the number 2 and then vaccines, as a hashtag we might be using to sort of promote some of the ideas from this event. So if you're on Twitter, please use that hashtag and include the Public Health Association at PHAA on Twitter. So I'll kick off with our first speaker, who's Dr. David Legg. David graduated in medicine, and after training in internal medicine, he moved into public health. Since then, he's blended various streams, including being a planner, a manager, a policy analyst, a researcher, teacher, and then activist. And he's approached all of these positions from a political economy of health perspective. He holds a position as Scholar Emeritus at La Trobe University, and he's actively involved in the People's Health Movement. And so David's going to kick us off by setting the global scene about the politics of access to vaccines and intellectual property rights, and in particular, what's been happening over the last few months in relation to COVID. So I'll hand it over to you, David.
Thanks, Belle, and welcome to everybody. And I would like to also express my appreciation of the Wurundjeri people on whose land I'm sitting. My presentation is going to be essentially an introduction to some Kim and Deborah Gleeson's, who will give you the substance. But let me start with some PowerPoint. So this should be showing as a slideshow from the beginning. There we go.
Yep, we can see it.
We can see it. So this is a mind map of what I want to cover. And I'm starting at the left-hand top side with a reflection on the role of solidarity in response to the pandemic, and the contradiction between the pressures of solidarity and the pressures of private profit. And then at the bottom left-hand, we've got the pressures of national self-interest. And then in the middle, we've got some of the institutional structures which have been set up. And in particular, I'm looking at the top at the CTAP proposal, which was proposed through the WHO for technology pooling. This was very much an expression of solidarity, because the idea was that companies and countries with technologies would share them on an open license basis. They'd share patents and technical know-how and data and so forth. That, of course, has not taken place, certainly not in relation to the vaccines. Then there's the Accelerator, which is a complex arrangement set up outside WHO, which has got 4 pillars, one of which deals with vaccines, and that pillar is called the COVAX, or involves the COVAX facility. The COVAX facility needs $18 billion, and so far it's got just over $3 billion, so that's a bit of a problem. Although there's recently been announced a little bit of additional funding from the World Bank, which is actually loan funding, $12 billion. How much, where that will go, it's not all that clear. Then at the bottom, we've got the emergence of vaccine nationalism, with the rich countries, many of the rich countries, buying up buckets and buckets of projected effective vaccine supply. What's going to happen now, moving to the right-hand side of the screen, is that we're looking at price barriers and access delays. The lack of funding for COVAX will mean that less money will be available to buy vaccines for poorer countries, and the slurping up of vaccines by the rich countries may well mean an undersupply for the COVAX facility, so again leading to access delays and barriers in terms of the developing countries. So the challenge that we're looking at is the possibility that the COVID pandemic will continue unabated in the developing countries, because if all of the vaccines as they become available are mainly used in rich countries. So that's another issue, is the issue of price barriers, which is quite a specific thing which is associated with the COVAX initiative, which means that if COVAX does in fact work, it will only be using donor funds for the first 20% for the low and middle income countries that it covers, which means that for 80% of their populations, they will be competing on the world market. And there are very few guarantees, if any, that they won't be ripped off by vaccine manufacturers at that stage. So the focus of this discussion then is therefore on the scaling up of local production, so that developing countries and countries in the global south generally can generate the funding they need, they generate the vaccines they will be needing through local production. One of the barriers to local production is intellectual property, and there is a proposal circulating which is called the TRIPS waiver proposal from India and South Africa, which is being considered by the World Trade Organization to waive the intellectual property restrictions which are part of the World Trade Organization's TRIPS agreement on intellectual property, so that manufacturers in the global south can pick them up, can do the manufacturing. So Deborah's going to talk about a little bit about the intellectual property issues, as well as talking about the Australian issues, and Sun will talk about the scaling up of local production. Now, in the remaining slides, if I can make them come. In the remaining slides, I was going to talk briefly about some of these institutions. CTAP, the COVID Technology Access Partnership, initiated by Costa Rica, adopted by the WHO, highly disparaged in very rude terms by pharma elites, and ignored by the high-income countries. It would have provided for voluntary pooling of patents, trade secrets, formulae, and so forth, but it's basically, as far as vaccines are concerned, dead in the water. Then there's this accelerator, the access to COVID tools, of which, as I said, there are 4 pillars: the diagnostics, the therapeutics, the vaccines, and the so-called health systems connector. So we're looking at the vaccines, which are run through SEPI, which is chaired by our own esteemed Jane Holton, and Gavi, the Global Vaccines Initiative. But have a look over here on the left and you'll get a sense of who is behind the accelerator. The Gates Foundation is behind all of these different organisations and is putting buckets of money into the accelerator. SEPI stands for the Consortium of Epidemic Preparedness Innovations, and it is funding epidemic preparedness innovation. Gavi, of course, has long-standing been involved in the vaccine business. The IFPMA stands for the International Federation of Pharmaceutical and Manufacturers Associations. So they have had a critical role in both the design of this system and the prevention of anything a little bit more radical, and so forth. And I won't go into the rest. The vaccines pillar comprises the so-called COVAX facility, which is a very complex, and I don't think I have time to go into it. It's a complex system for both advanced purchases of potential vaccines in advance of their being actually demonstrated to be effective, as well as being a channel for donor funding to support low-income countries and lower middle-income countries. It's proposing to push the development of vaccines through push financing, which is, it's hoping to have 9.4 billion for that, and for pool financing, which is advanced market commitments. The only other thing I want to talk about on this slide is the WHO allocation framework, which the WHO has estimated that roughly 20% of each of a national population is seen as a priority for getting the vaccines, and 80% might be of a lower priority. So the COVAX is actually only a tool for getting the first 20%. We could come back to this later. Then, of course, we've got the bilateral advance purchase agreements, which has been described in the press as vaccine nationalism. By late August, the US had deals with 7 companies, securing 800 million doses and costing a total of 10 billion. The United Kingdom is the world's highest per capita buyer. European Commission's also bought, and Australia's also bought. This is buying up vaccines before they've been proven to work, and in general, without anything very much in the way of conditions with respect to prices. Although it's terribly obscure because a lot of these agreements are secret. This is a picture of the purchasing on the bottom. We've got doses per capita, and down the side we've got the countries. So you can see that the United Kingdom has already paid for 5 doses per capita. The United States has aiming for that, but at this stage has only paid for 2 doses per capita. China has secured for itself much less than 1 dose per capita, and the total available at the time that this was produced in early September for the low and middle income countries through this COVAX facility is, again, sort of 0.1 dose per capita. This was published in Nature. This is a slightly different picture about where the vaccines will be produced. And again, they're largely produced in the rich world, although India will be producing quite a lot, and China in some degree. Okay. So just to give an example of why this is possibly a bad risk of inequality and inequity, I've compared here 2 scenarios. The first scenario has the have countries, the vaccine nationalists, which constitutes about 2.5 billion people. Let's say they vaccine 50% of their population in the first year. Now that will use up all the vaccines, which means that the rest of the population, the 4.5, largely in the global south, will have no vaccine in the first year. Scenario 2 would have all countries vaccinating 20% of their population in the first year. That's 7 billion by 0.2 number of people. And but the other 80% would get no vaccine in the first year. Now, my calculations on a very rough back of an envelope is that scenario 1 in the first year is associated with 45 million cases and 1.2 million deaths. Scenario 2, the more equitable one, sees 18.2 million cases and 455,000 deaths in the first year. These calculations are rough because they call upon some parameters which we really don't have very good data on, but they indicate the threat which is being addressed, the possibility that the delays and the price barriers associated with the so-called COVAX and the Accelerator and the refusal to consider waiving the application of the TRIPS agreement could lead to a very significant number of deaths. So this is the
1 minute, we're just at times if you want to wrap up, David.
I'm wrapping up, Belle. Here's one, this is the last slide, it's the slide I started with. And it's just to remind you of the logic of what I'm trying to work towards, the need for scaling up local production, the need for addressing the intellectual property issues, and the risk for the global south of being deferred and delayed and then facing big price barriers in the outcoming years. And then for us to be understanding the institutional structures and the politics and the economics of those structures. So I'm looking forward very much to hearing my colleagues elaborate on these issues. Thank you, Belle.
Thank you so much, David. That was really clear. And for me, who sort of follows around the periphery, to get a really interesting sketching the scene of some of the key developments and what the differences are, and what the big issues are for low and middle income countries. So that helps us sort of nicely go on to Sun Kim's presentation. So Sun Kim is a Director of Health Policy Research at the People's Health Institute in Seoul in South Korea. She has researched vulnerability in healthcare and access to medicines and pharmaceutical production from a political economy of health perspective. She has served as Southeast Asia and Pacific Regional Coordinator of the People's Health Movement since 2019. And Sun is going to sort of drill down in some of the issues for local production and tech transfer low and middle income countries. So thank you, Sun.
Thank you, Belle. I'm also very thank you for inviting me to this webinar, very interesting webinar. In the last presentation, David showed the global scenes that looks at to produce highly inequitable access to COVID vaccines, and particularly during the first year or so. So in this presentation, I'm going to argue that for equitable access to COVID vaccines, cooperation around research and production capacity is critical. So this is the overview. First, let me show the capacities and incapacities of low and middle income countries in terms of research and production of COVID vaccines. And secondly, we will see that scaling up manufacturing capacity in low and middle income countries backed up by technology transfer is critical. And, So lastly, we can conclude that global and regional cooperation, including South-South and North-South cooperation, is urgently needed. Yes, first, the capacities and incapacities of low and middle income countries. So WHO provides landscape of candidate COVID vaccines. As of October 2nd, there were 42 vaccines in clinical evaluation and 151 vaccines in preclinical evaluation. And among these, many are being developed by low and middle income countries, and most of them are in the public sector, public research institutes or public vaccine manufacturers. So they do have the capacities for R&D and vaccine manufacture. And let me share the two models of research and production for COVID vaccines. And one is the Brazilian and Indonesian model. It is somewhat rather realistic, as they are the hardest hit countries by COVID. So on one hand, they are procuring foreign vaccines with making deals involve clinical trials as well as manufacturing. So effectiveness of such deals in terms of technology transfer depends on the details of the agreements and the pre-existing state of technological development. However, the detail of many of the deals has not been fully disclosed. On the other hand, they are also developing their own vaccines. They say, even if the foreign vaccines they made deals fail, at least they can learn the technology. And the Thai model, they say, Thai model is more ambitious and shows the capacities and incapacities more clearly. They say that they learned from the 2009 H1N1 pandemic, when most of the low and middle income countries could not secure enough or any vaccines for their people due to the hoardings by the high income countries. So they are trying to they're trying to develop their own vaccines in each platform. So inactivated DNA vaccine or RNA vaccine, protein subunit vaccine, VLP vaccines. One of them, a candidate RNA vaccine, was expected to do the clinical trials first outside high-income countries, but they are currently waiting for the experimental vaccines to be produced by foreign production capacity. So they say that once the trials have completed all stages, they themselves, Thailand itself, will start output. But it looks quite obvious that they cannot arrange the manufacturing facilities for all of the platforms at this stage with huge risk. So too many projects may mean no scale-up economy, and there definitely are possibilities of skipping many steps if there was a technology transfer. Considering the global scenes, especially the scene that high-income countries are buying out most of the global supply through the bilateral advanced purchasing agreements, fast and enough scaling up of volumes of supply is critical for equitable access to COVID vaccines. Even now, vaccine companies are negotiating with some contract manufacturers, but still not enough for the global need, and most of those are locked up for high-income countries. As we saw in the last slide, low and middle-income countries already have research and production capacities with possibilities for improvement. One of the possibilities is that the scale-up economy of R&D funding and the manufacturing facilities with global and regional cooperation. And the other possibility is to enhance the efficiency of and not to duplicate the research with technology transfer. So in this regard, scaling up manufacturing capacity in low and middle income countries will be the key. Of course, IP, intellectual property, is one of the main barriers that will be dealt with by Deborah in the next presentation, but not the only. So even after abolishing some patent or any other IP, there will be huge need for technology transfer from the perspectives of vaccine manufacturers in low and middle income countries. So technology transfer as moving the knowledge about the ability to produce a vaccine will enhance the effectiveness of the manufacturing capacity in low and middle income countries. So lastly, if local production is to play a key role in supporting the equitable access to vaccines, a more organized approach to promoting local production and technology transfer is needed. It means it might include landscaping, facilitation, and partnership development, and organized support for technology transfer. So we already have some current initiative for landscaping and for partnership. For landscaping, the WHO landscapes of COVID-19 candidate vaccines, and CEPI did a survey on the global manufacturing capacities, but this one is not the systematic one. And these surveys do not report on nationalities, public or the private, or how much public infrastructure or funding invested. That is the biggest limitation. And the current partnership, we do have a pre-existing partnership named TAP to promote a combination of technology transfer and capacity building for R&D, production and supply for PPE, medical devices, and diagnostics, not to expand to the medicines and vaccines. So there is a need to expand to those sectors. And according one estimation, technology transfer may be possible in 6 months, 60 to 70% more quickly than usual at scale. So it means that we should act now to organize a platform to do this for the global and regional cooperation for scaling up the manufacturing capacity in low and middle income countries. Yes, that's all.
Thank you, Sun. That was just before it being at time, so you were very efficient. And I just took some notes. I won't sort of ask you questions now, but I found that really interesting in thinking about opportunities for scaling up for regional and what that could look like in the Asia, Southeast Asia and the Pacific. And so I think we could have a good discussion about that. So I'll just move on to our third speaker, who's Dr. Deborah Gleeson. Deborah is Senior Lecturer in Public Health at La Trobe University, and her research primarily is on international trade agreements and public health, with a specific focus on access to pharmaceuticals. Deb is co-convener of the Public Health Association of Australia's Political Economy of Health Special Interest Group, and she plays an active role in the advocacy of the Public Health Association of Australia on trade agreements, public health and access to medicines. And so one of the things Deb is going to speak about is some of the things that the Australian government could take in terms of contributing to equitable access and these issues that we've spoken about, and we can lead on then into our discussion and questions. So over to you, Deb.
Thanks very much, Belinda, and thank you also to David and Sun King for setting the scene so well and those excellent presentations. I'm just going to share my slides. Try again. Okay. So I'd also like to begin my presentation by acknowledging the traditional owners of the land, the Wurundjeri people of the Kulin Nation, and paying my respects to the elders past, present and emerging. So the focus of my presentation is on what's happening in Australia, what's the Australian government currently doing, and what could Australia do to advance equitable access to vaccines. So I'll look first at the current situation and then what Australia should be doing in 3 areas: ensuring access to COVID-19 products for all Australians, promoting timely access for low and middle income countries, and also how Australia could look at taking a long-term view in terms of promoting access to pharmaceutical products in the future. So David talked a bit about the mechanisms that we have at the global level for promoting access to affordable COVID-19 vaccines, and COVAX is really the central mechanism that we have and our best hope for providing access in an equitable way. The Australian government has signed up to COVAX and has invested $123.2 million in purchasing vaccines through COVAX for Australians. It's also provided $80 million specifically for low and middle income countries. So this is for COVAX's advanced market commitment for low and middle income countries. But this $80 million is from existing aid funding. It's not new funding. and it's not going to go very far in terms of providing access for low and middle income countries, even if we just looked at the countries that are in our region that Australia already provides aid funding to. So this commitment really is very inadequate, particularly in terms of, as David mentioned, the COVAX needs $18 billion and only has $3 billion so far, just in order to meet that 20% kind of really basic threshold for providing vaccines to the people who are on the front lines and the most vulnerable people in low and middle income countries. In the meantime, Australia has invested $1.7 billion in advance purchase agreements for 2 promising vaccines. One is the vaccine that was developed at the University of Oxford and is now being manufactured in partnership with AstraZeneca. And the Australian government has made arrangements to purchase 30 million doses of that vaccine. And then the other one is the one that was developed at the University of Queensland in partnership with CSL. And they've arranged to purchase 51 million doses of that 2-dose vaccine. So both of these vaccines, assuming they turn out to be safe and effective, which is of course unknown at this stage, but the plan is that they'll both be manufactured in Australia by CSL, and the government is investing a lot of money in CSL to upgrade the production facilities to be able to do this. But of course, these are still in clinical trials. The Oxford AstraZeneca one is in the phase 3 trials, and the University of Queensland one is in phase 1 trials at this stage. And there's no guarantees that either of them will prove safe and effective, and that the government's $1.7 billion investment will actually pay off. I think it's very short-sighted of Australia to place so much stake in these 2 particular agreements rather than investing in COVAX, which has a whole basket of potential vaccine candidates. There's 9 currently in the portfolio and 9 potential candidates to be added to that. So this is something that we should be aware of as Australians. It's a bit of a shortcoming in Australia's strategy. So in terms of ensuring access to COVID-19 products for Australians, there are a few actions that Australia could take. As David and Sunkin have mentioned, a big barrier to access to COVID-19 products is the fact that companies have intellectual property rights over the products that they produce, particularly patents. And patents are usually in place for at least 20 years, and they prevent anyone else from making and selling the products. Fortunately, we have some legal safeguards in our patent law that enables us to override patents in circumstances of public health emergencies and other situations where we need to use these types of mechanisms. And these are called compulsory licensing and Crown use provisions in our Patent Act. They're quite clunky to use, and some other countries have actually revised these legal safeguards to make them easier to use and to remove the requirement that the government would need to negotiate with pharmaceutical companies first before invoking them and overriding the patent. So that's something that Australia could look at doing. It'll also be important for Australia to revoke its voluntary waiver at the World Trade Organization, which David spoke about before, to ensure that we can import pharmaceuticals that are manufactured under compulsory license from other countries. So many years ago, Australia was very short-sighted, like a lot of other wealthy countries, and decided that it probably wouldn't need to use its compulsory licensing provisions. It didn't have the foresight to imagine the current situation that we have with a COVID-19 pandemic, and signed away its right to actually import cheaper versions of products without the permission of the patent owner. So that's something that needs to be remedied. And of course, Australia needs to invest more money in COVAX rather than in these risky bilateral deals, which also have the effect of you know, as David said, slurping up the supply of vaccines and reducing the amount that's available for countries that really need them. In terms of promoting timely access for low and middle income countries, it will be really important for Australia to boost the funding for COVAX's mechanism for funding vaccines for low and middle income countries. Australia also needs to support the COVID-19 Technology Access Pool, or CTAP, which David explained earlier. This is a vitally important mechanism, particularly for advancing access to vaccines, because it's not enough just to share the information that's in a patent to manufacture a vaccine. The processes are really complicated. Sometimes you need access to the original cell line that's used to grow the virus. It's such a complex process, and so we need to have mechanisms for the know-how and the technology and the process information to actually be shared. And so countries really need to get on board with this process. And they also need to make sure that they're using enforceable provisions in funding agreements when they fund research and development to mandate the sharing of intellectual property. Our Prime Minister, Scott Morrison, has said, you know, if we find the vaccine, we'll share it with the rest of the world. But actually, we need to make those sorts of rhetorical commitments concrete by actually putting these mechanisms in place and making sure that pharmaceutical companies actually share the information that the developing world needs to be able to manufacture their own versions of these products. Australia also needs to support the proposal by India and South Africa to waive the intellectual property protection for COVID-19 products. This is a really, really important move, and India and other countries need to get behind India and South Africa and support that proposal and make sure that intellectual property doesn't become a barrier to sharing these really, really important products. And Australia could also look at regulating the voluntary licensing practices that impede access to vaccines and other products. So pharmaceutical companies tend to charge high prices for high-income countries and then negotiate voluntary licensing agreements with generic manufacturers to produce low-cost versions for low-income countries, but often the middle-income countries end up missing out. And I think, Belinda, this must be my cue that I've only got a minute left. Is that right? Yep, thank you. So we need to look at regulating those types of practices so that companies are actually forced to make their products available at a reasonable price for everyone in the world, not just a select set of countries that they decide are deserving. In the long term, Australia needs to support initiatives to find alternative ways to fund research and development that don't rely on patents and intellectual property. The intellectual property regime that we have is really fundamentally flawed because it's based on monopoly rights, it's based on excluding others from the market, and it really is not able to deliver timely and affordable access to pharmaceuticals. This isn't a new problem. It's not something that has been created because of COVID-19. COVID-19 has just brought it into really sharp relief and really pushed it into all of our faces that we need to do something about this problem, and we need to address it for the long term, not just for the immediate crisis that we're in. We need to explore global mechanisms to mandate the sharing of intellectual property in public health emergencies. We need to help build the manufacturing capacity in developing countries, as Sun King mentioned. And we also need to look at the way that trade agreements have been gradually expanding the intellectual property rights available to the pharmaceutical industry and really totally rethink what we're doing in this space. And I'll finish up there. Thanks very much. And sorry for going a little bit over time.
No, that's fine. Thank you so much, Deb. All right, so we're going to kick off the discussion. We've got 15 minutes. I don't see any questions yet in the Q&A, but please post your question in, or if you want to raise your hand, I'll keep a lookout for the raise hand function. I do have some questions I might start off with. So the first one was, what appetite do we think there is for a regional model of vaccine production. So what I got from your presentation, Sun, was when you were talking about the fact that there are many low and middle income countries that do have capacity, although that varies depending on the technology, and that there's this issue where we need to think about scale. And so you mentioned a more organized approach. For example, if countries were to pool together their resources in a regional way, is there an appetite for that in our region? And if there is, Deb and David, have you heard whether the Australian government has offered any comments about whether they would support something like that?
Not hearing you, Sun.
Yeah, we can't hear you, Sun. I'm not sure. No, we can't hear you. I think we can hear you now. Yep.
Okay. So I did think about the regional model for cooperation for local production, actually. There might be lots of possibilities to think about, but most of all, I think the WHO as a legitimate body representing the member states around the world, including the low and middle income countries, should be the lead for that regional cooperation. So something like WIPRO office could be the lead to, first of all, they can do the landscaping for the manufacturing capacities from the region and their capacities, the technological development, and whether they are public or private. As I said, public or private, what kind of technology do they need, and whether there is a kind of possibility to leverage the public funding or infrastructure as a kind of conditionality to ensure the access to information, data, or knowledge. And another aspect is that I didn't mention about the high-income countries from this region, but South Korea, Australia, Japan already are developing their own vaccines. All are in the clinical stage. So if the governments from these countries, these high-income countries from the region can take the lead to provide the technology transfer and to any kind of cooperation, they might be very helpful to move forward that kind of idea to reality. Yeah.
I'm not aware of the Australian government looking into any of this, Bill. I haven't. I'd be slightly surprised if they had.
I think that one of the things that we probably need to look at it in terms of the Public Health Association of Australia is how can we encourage Australia to take more of a leadership role in the region. I think there have been examples of where Australia has taken a leadership role in terms of advancing access to medicines, or at least trying to mitigate some of the effects of trade agreements in the region. And so it would be good to see Australia actually stepping up and doing more to help other countries in our region, and in a variety of ways, including through COVAX, but also through other mechanisms.
Just following on from that, I was just thinking about, for those on the call who would know about when the HIV/AIDS epidemic hit and HIV/AIDS medicines were developed, that there was a lot of kind of movements and activism around access to HIV/AIDS medicines, which led to the Doha Declaration at the World Trade Organization that everybody should be able to have access to essential medicines. And so I wonder, are we not seeing commitment from Australia and others to the low and middle income countries yet, because we don't have these vaccines aren't actually out there and available yet? So I've heard from all of you about how we're at this moment where the rich countries are trying to build up as much supply as they can, or get as much supply as they can when it becomes available, and they're not offering funding or technology transfers, support to the low middle income countries. Will it take the vaccine to actually be developed and for people to see the big disparities in who actually gets it for there to be activism? And if so, what do you think we can do to try and make that activism or that stark inequality clearer now before it's almost too late, or before we see these inequities and people not being able to access the vaccines as they come on the market? Happy for anyone to jump in.
Well, I might start. I think that I would place greater weight on the existence of a community-based constituency in the lead up to Doha 2001, the Doha Declaration. There was a strong international constituency arguing for access to affordable access to HIV medicines, very much based on the gay community. And it was, there was solidarity between the global south, particularly in South Africa, and the global north, particularly through organisations like ACT UP, who pestered the American administration until they rolled over and stopped supporting Big Pharma. So, I mean, it'd be nice to imagine that all the groaning and grieving that goes into people whining about their being locked up for too long, if that could be remobilised and go into a little bit of advocacy, and if we could find ways of expressing the sort of international solidarity between the wealthier countries and the poorer countries, that also would be terrific. I think there's a lot that can be done at the community level. There's a sign-on letter which is still available to be signed on, supporting the waiver. I might put that in the text box if I can find it. And there's work which we could be doing, building a movement for change in Australia, along the lines that Deb has described.
I think I'd just add on the question that you asked, Belinda, that by the time a vaccine is actually, a safe and effective vaccine is actually out there, if we wait for that to happen, it's already too late if the rich countries have already bought up the supply of that vaccine. So we really need to get on the front foot and make sure that we're really pushing governments very hard to prevent a situation where so many people in need are just completely missing out.
Thank you. I'm wondering if participants who are listening in want to offer any thoughts that they might have, from the perspectives that you're in, or if you have any questions. So I'll just continue with another question I had sort of linking into this, which is, what has worked with the Australian government? So you mentioned before, Deb, that the Australian government has taken positions in support of access to medicines in the past. What do you see as the messaging or the coalitions of actors that have helped push that along in terms of how we as the Public Health Association of Australia and interested community could sort of push Australia in that direction?
Well, I think where our advocacy has been successful before, it's been where there's been an alignment of interests, I guess, in terms of protecting access to medicines for Australians as well as for developing countries. So, for example, when our pharmaceutical benefits scheme has come under threat from proposals by the United States in trade negotiations, then we've seen a really strong groundswell of support from the Australian community, from non-government associations, and politicians have been, and the media have been really amenable to taking on messages about the need to keep medicines affordable. And I think this is a good example of an issue where we are all at risk. Obviously developing countries are much more at risk than countries like Australia. But actually, if we don't get the solidarity, if we don't get the investment in these equitable mechanisms, then we're all at risk of missing out. If the government keeps on making these bilateral deals and not actually investing in COVAX. That's a problem for all of us.
Bill, I wonder if I could throw in another issue which I didn't have time to talk about in my 10 minutes. It's about cost. It's not just about access through production. It's about the fact that there have been some gestures that vaccines will be supplied to developing countries at the cost of production. But it's likely that they would be only for the first 10 or 15 or at best 20% of the population. And after that, you're looking at either tiered pricing, in other words, that the pharmaceutical companies can set a price that they think a local market can bear, or alternatively, the open market, the open global market. I just want to make the point that the COVAX facility is only open to low-income countries and lower middle-income countries. Upper middle-income countries are expected to buy all their vaccines on the open market. And just to make the point also that the price of medicines and vaccines, because it's a global market, is a much higher proportion of total health expenditure in developing countries than it is in Australia. And that therefore, if countries are required to buy medicines and vaccines on the open market, you are taking away funding which might otherwise go to healthcare workers, community health workers, doctors and nurses, in a much bigger degree than would be the case in Australia. So the issue of prices is a major theme which should be running through this, I think.
So then I'm thinking about the arguments that need to be made in order to get to that solidarity that would ring true with the government that we have at the moment. So I don't know if any of you have any thoughts about, so the fact that it's going to cost, that it's not just low and middle income countries, it's Australians who are going to miss out with the way things are going at the moment, except for perhaps a certain percentage of Australians. It's about the costs. What other arguments do you think would help win over the government, or what kind of evidence could the public health community generate in making those arguments?
I think that even from self-interest, it's not in Australia's interest to have large unvaccinated populations on our doorstep. If you think of Indonesia, for example, if Indonesia can't vaccinate enough of its population to achieve herd immunity, then that's a big problem for Australia, with the risk of reintroduction. We also have the problems of travel and borders and things like that. So life isn't going to go back to normal in many of the ways that we want it to until we've achieved a reasonable level of immunity across the world, not just in Australia.
Deb, I wonder if I can challenge you a tiny bit on that, because I see a dichotomy, a divergence within the international discussion of so-called global health security between the discourses of security, meaning we must protect ourselves from the other, versus security meaning these people are my brothers and sisters and I want to see them looked after. And so it's a tricky one, because it's so obvious. What you just said is so correct, but it's tricky about engaging in that discourse without supporting the kind of extreme, at the extreme end, is sort of xenophobia. We must protect ourselves from the other. I don't know how to do that, how to talk about it in that way.
We've got a question from Carolyn Lloyd. Carolyn, if you want to take yourself off mute, or we might get help to take you off mute if you can't.
Not hearing you, Carolyn.
Caroline, if you're talking, we can't hear you.
Can we use the box?
If it's not working, do you mind typing, yep, Q&A? Oh, she didn't mean to raise her hand. We're almost at time, and I guess I wanted to offer the panel some last-minute comments. I am thinking about how we, as the Public Health Association of Australia, and also as the People's Health Movement, with Sun Kim here as the regional coordinator, could take on some action around this in terms of driving an equity-focused agenda for access to vaccines. So if any of you wanted to offer some reflections on that before we wind up.
I'd like to leave to Deb, who's the expert in domestic advocacy and international advocacy for that matter, but just to say that as far as the People's Health Movement's concerned, we actually have a trade and health circle which has been discussing these issues, and people Australians would be most welcome to join that trade and health circle. They just need to write to tradeandhealth@phmovement.org and make contact with the convener of that circle.
Do you mind just typing that into the chat, David?
Yeah, sure.
Yeah.
So I think...
Sorry, thank you. Go ahead.
Yeah. Okay, thank you. So I think at least we can start with supporting the waiver proposal by the Indian and South African government first, today and tomorrow, and tomorrow's day after tomorrow, because the council meeting will be on 15 to 16, right? So after that success, we can proceed to support the local production and technology transfer with waiving the proposal and more organized way and institutional way to do the local production and technology transfer. Yeah, and we as PHM and as local CSOs, we can do that movement locally and globally.
I've put, Melinda, I'm sorry, I've put into the chat box, you may have seen the website where you can actually sign on to the support for the waiver.
I can't see it. I don't know if that's just me. But,
as far as I know, this morning, they this was the organizational sign-on letter, right? No?
Yes. No, well, everyone's got organisations. Yeah, create an organisation. Sign on.
Yeah. The sign on.
Morning. Yeah, this morning there were more than 360 or 70 organizations that supported the letter.
Mm-hmm.
So if I could just add, Belinda, that the Public Health Association of Australia has been engaged in advocacy on these issues for a little while now. We've written to the Health Minister, Greg Hunt, about some of these issues. We've been making submissions to inquiries and parliamentary committees, and we have also signed on to international initiatives like the letter about the TRIPS waiver. There's definitely a lot more that we can do, and these issues are not widely known. And I think people are very distracted by all of the other things that are happening in the news at the moment, and access to medicines and vaccines is not kind of at the front of mind for a lot of people. But these issues are really urgent and need a lot of attention. If people are interested in getting involved in PHAA advocacy, probably the best thing to do to start with is get in touch with me. My email address is d.gleeson@latrobe.edu.au. The Political Economy of Health Special Interest Group has a trade and health working group, which is working on submissions and things like that, and people are welcome to get involved in that if you've got an interest in this issue. Thank you.
Yep, I'm just going to quickly drop in a link to the chat before we wrap up for those of you who are members of PHAA and you would like to get involved in the SIG that Deb just mentioned. And it's also got Deb's email address in that link too. Okay, so we're at time now. I just wanted to say a big thank you to the Public Health Association of Australia for hosting us, and for David, Sun and Deb for coming and sharing some really, complex ideas that you've sort of crystallized into some key points, and that's been really useful. And so what we'll do is when we have the recording finalized, we will share it around with everyone who's registered, and it will be up on YouTube. And so I encourage you to please share it with your networks. And then if you're interested in getting involved with either the People's Health Movement or the Political Economy of Health SIG, we look forward to more discussions and more advocacy for equitable access to vaccines. That's our aim. So thank you, everyone. And we'll share the recording with you perhaps in the next few days.
And thanks to Bridget.
Oh, and Bridget as well in the background. You've been our secret host, making sure everything's running smoothly. So thank you, Bridget.
Thanks very much, Belinda, for chairing, and to the other panellists. Thank you.
Okay.
Thank you. Bye.
Bye, everybody. Look forward to seeing you again soon.
See you.